Welcome back to Sisterhood and Surgery. Today's topic is our postponed topic from January when Houston had terrible weather and it snowed and therefore everything shuts down. But today we're talking about leadership development and its importance in surgery. And of course I have my co-host here, Palma Shaw, and our two guests. Thank you again for taking your time out in January and then also in February for this. So I'll start with the introductions. Dr. Manuel Garcia Toca earned his medical degree from and I'm sorry if I'm saying this wrong, the Universidad Anahuac in Mexico. And did I do that okay?
That's pretty good.
Okay, in 1999, and later obtained a master's degree in health policy from Stanford. His journey in general surgery training was completed at Brown University, followed by vascular surgery fellowship at Northwestern. He is currently the division chief of vascular surgery at Grady Memorial Hospital in Atlanta and is an associate professor of surgery at Emory University. Additionally, he contributes to the field as the chair of the leadership development program of SVS. Welcome.
Thank you. Thank you.
And I'd like to introduce Dr. Grace Wang. Thanks for joining us tonight. She's an associate professor of surgery in the Division of Vascular and Endovascular Surgery at the Hospital of University of Pennsylvania in Philadelphia. She completed her general surgical training at Massachusetts General Hospital and then a vascular and endovascular fellowship at HUP, where she then stayed on as faculty. Her clinical interests include carotid endarterectomy and carotid stenting, endovascular repair of thoracic and abdominal aortic aneurysms, and she's also the clinical director of the vascular lab at the Hospital of University of Pennsylvania. She completed a Master's of Science in Clinical Epidemiology through the Center for Clinical Epidemiology and Biostatistics at University of Pennsylvania, and that has given her the ability to analyze large data sets and create predictive models to understand poor outcomes in vascular surgical patients. Her research focuses on using large-scale databases to study trends in practice, predictors of outcomes, and gender and racial disparities in access to care in vascular surgery. She's utilized the National Inpatient Sample, the National Surgical Quality Improvement, as well as the Vascular Quality Initiative and the Chronic Renal Insufficiency Cohort registries to conduct these studies. She's active in the VQI and is the co-chair of the Research Advisory Council and plays a critical role in facilitating research projects using this database. She's also the chair of the VQI TVAR and Complex EVAR Registry, as well as the steering committee for the GORE TBE registry. Welcome, Grace.
Thank you so much for that kind invitation. I'm so excited to be here tonight.
And remember, this is a live show, so if you have any questions or comments from the audience, please send those in. You can join by web, go to pollev.com, enter DeBakey, or join by text through your phone, text DeBakey to 37607 and text in your question, and we'll get those answered for you. Palma, do you want to start with the first question?
Sure. I think this is an inspiring topic, and I appreciate both of you who participated in the SVS leadership cohort. I think Grace did it earlier than Manuel, I believe, but I know that you learned quite a bit, and I appreciate Ken Slaw's contribution to that from the SVS executive leadership. And so I learned a lot about this in my MBA. And so I find a lot of these topics fascinating, and I felt that when I did a lot of the coursework for this type of leadership, different topics that we use, it was important in my day-to-day work as a vascular surgeon. So I guess I'd like to start off asking each of you what your sense is of how do you define leadership? What is a leader, and what if someone, a trainee, said to you, well, what does leadership mean, or why should I do this? What would your answer be? Grace, what do you think about that?
Oh, sure. Yeah. Thanks, Palma. So the first thing that I felt was really eye-opening during that leadership training course, which was excellent, was that leadership is something that can be embraced by anybody at any level. You know, at one point I was like, well, when I become a division chief like Dr. Palma Shaw, then I'll do a leadership course and learn how to do that. Or when I lead, Grady Memorial Hospital, then I'll enlist in these courses. But really, it's about engaging in these behaviors that are going to allow you to influence people around you to get things done right? So we do that every day, as you mentioned before, Palma. It doesn't mean that you have to be the division chief and you don't have to be making large-scale decisions about FTEs and things like that, but it's really about, how do I get the proper care for my patient who's on the floor, who's going to need multidisciplinary consultation from other services. There may be sort of competing, purposes in terms of how we're going to manage their post-operative care. How do I engage the APPs? How do I engage the trainees? How do I engage all the people that we need to involve in order to get them the care that they need? So I think that one of the things that was eye-opening is that you really, need these skills to be able to take good care of patients, no matter where you are, whether you're a trainee or a younger faculty member. And I think that one of the most salient things is that you really have to be consistent and transparent in what you say that you believe in, and then make sure that your behaviors are consistent with what those things are. That, I think, is the absolute number one thing that is important as a leader. I'll sort of open up with that, and I'll let Manuel continue.
Yeah, no, I couldn't agree more with everything you said. Leadership is not about rank or authority. And I mean, if you read, there's so many definitions about leadership. The one that I like the most is the one that says that leadership is anyone that embraces the responsibility to see those around rise. So you, as a leader, is not about you. It's about the person to your right and to your left, and make sure that they're doing well. And Grace is right. Like, it's not, you can do that without having any rank or authority. And you obviously need to model that way and behave the way you want other people to behave, and also trust them, and so they can trust you.
And I think that you don't just because you're a chief or running a division or a department doesn't really make you a good leader, right? I think years ago, people got promoted because they're very strong in research, but they never received the training or any of the background that they needed to actually lead a division and have the interpersonal skills to relate to different people and get things done. So I think at the end of the day, it's about strategy. It's about how you can stand back and think, how am I going to get from A to B in the shortest distance, and have everybody basically get along and bring them onto to my way of thinking, or figure out what they need and then help them be better. So, Linda,
I was going to say, I agree with you. The way people get promoted is because you're really good at your craft. We're good clinicians, good researchers, and you get promoted, but that doesn't mean that you're a good leader. And you don't, the problem is that you get into those positions and then suddenly you need to know all those skills. And that's the worst time to start practicing those skills. You want to know how to do it before, so you don't make all these mistakes.
Do you
I also think that...
Oh, sorry. Go ahead.
I think that there are some generational differences too, because I think that even when I was sort of growing up as a medical student or as a trainee, like a good leader sort of looked different than they do now. It was very sort of top down and very directive, and this is what's going to happen, and it's my way. And I don't think that type of leadership is as efficacious nowadays, because we really function well in teams, and we need people to feel engaged, and as if they're part of the, whatever strategy that you have that you mentioned, Palma, or the vision for the future. If people don't feel engaged, they're just simply not they're not on board, and you can continue to kind of say, well, I want this and this is going to happen, but it's just not going to be successful. So I think that modern day leadership has changed a lot, and I think given how complex our health systems have become as well, it just seems like where everything's sort of conglomerating together, or the affiliations with health systems become more and more complex. The need to have that sort of strong leadership vision bringing everyone together is getting harder and harder. But in some ways, it does emphasize the fact that we are, the team approach is really just so essential nowadays.
Yeah, they call it more like lateral leadership, that there's no hierarchical, like the algorithm, and then you need to influence your peers. And sometimes it's tough because there's no power. It's just, you just need to know how to have those difficult conversations and then trying to influence people.
Absolutely, yes. Do you think that there are innate qualities that make a good leader? Being the devil's advocate of, is it something you can be educated on, or do you think there's something in great leadership that's there already?
Manuel, you want to take a stab at that first?
Sure. Definitely there are like people that have character and that they are proactive and they have a vision. People are going to follow them, right? So, and I guess as surgeons we have some of those traits, but I don't believe that you're born. I think leadership is a skill, and the more and more like I read about it, is the more I realize that I need to work on it, and it's something that you need to work every day. So and be thinking about it. I think it's a never-ending study if you wanna do good things for the people you care about.
I think that there are certain people that have these sort of innate talents. They have that sort of outward extroverted personality. But there is that skill set that is necessary, and I think that that's what Manuel was alluding to. It's true. During the leadership development program, they referred us to several different references, and I think that every time I opened and perused a book, I was like, wow, this is really eye-opening, like, just thinking about things that way. Or I'm really good at this, but I tend to be more introspective with this, and I really need to be more open about how I'm, thinking about how to solve a problem. And so I think that some of it can be innate, but a lot of it can be learned. And Ken's Law always, espoused that it's really the practice of leadership that's important, like a muscle. And that's why we had those virtual leadership seminars, and that's why we practiced, difficult case scenarios, and it helped us to all recognize these leadership challenges that we encounter every day. These very intense conversations with our cardiology colleagues. Especially in our specialty where there's so much potential conflict or overlap with other subspecialties. So I think that it's really multifactorial. It can be learned, and it does take practice.
Do you think it's different for women and men? I really think that women are coming from a different place in leadership than the men. I feel like oftentimes it's just assumed, of course, that guy could be chief of the division. Whereas, well, we're not sure if that woman, maybe she's soft-spoken, or maybe is she really prepared to be at that level. I think many of the women feel that we need all those 10 boxes checked off before we could take on that leadership role, and the guys have about 5 and figure they're going to work it out. So I don't know, in a leadership training, if I were training people to be leaders, would I approach men and women differently, or would I just let them all kind of figure it out? Because I feel like in my MBA and maybe in your leadership cohort, everybody was just thrown together. There was no, but I wonder if you really think about it, some of the women are coming from a slightly different place. I don't know, what do you both think about that?
I don't, I'm not in a division chief role, so I don't know that I can really comment on whether or not separate, gender specific training would have been better, but I hear you, and I understand what you're talking about. I think that, people just feel comfortable having more training sometimes to prepare them for a role, and that's a separate issue. I think that it'll be up to people like yourself who are in that, division chief role and who've been through the training to really allow us to understand better how we can co-create these programs if that's what it needs. Or maybe we just need to develop, some sensitivities within one big program so that we can all learn from each other about how to make up for some of those differences. Similar to vascular surgery treatment, right?
Now, what are your thoughts on that? As a man going into the leadership training, did you feel that it was just a natural thing?
No, I mean, and that's a great question, Palma. We actually looked at all the evaluations that on the leadership development program to see, I mean, if there were any differences. And it's interesting that, like, I think women, they get less opportunities to show those like traits or skills, and that's why they may get evaluated lower. But it's because they're not getting the opportunity to show those skills. So I think, I mean, we're equally capable. It's just that we need to give more opportunity to women to be on leadership positions.
I just want to clarify, I'm not a chief. I'm a program director. I'm not the chief here, but I think we can lead in different ways, societies and different things that we do, Linda, do you want to bring up the next topic?
Yeah, so I had a question relating to what y'all were talking about, the course. So what did the course teach you about handling conflict? And like key takeaway points.
I think that I can start with that. They would come up with these scenarios that hopefully harken back to something that we had all experienced as vascular surgeons. And one of them was, had to do with turf wars, and a cardiologist had placed stents and they had occluded, and the patient came back and was questioning why myself as a vascular surgeon was recommending a surgical bypass when, previously stents had been performed. And so, during these sort of discussions, we focused on how important it is to kind of stick to the facts, not have our emotions sort of take over. And the facts were that the cardiologist was doing what was in his skill set and in his ability to treat the patient. And these are the facts. You don't need to throw the, heart doctor under the bus and things like that. And to really understand where the patient was coming from as well. Like, they don't need to know about turf wars, right?
Yeah.
And then understanding that, your role as a vascular surgeon is just to understand that it's for them to understand that you offer both therapies and you're recommending open surgical, repair because that's the best way to revascularize them after these endovascular therapies have failed. But I think that it was good to sort of de-escalate some of the immediate reaction from some of these case scenarios. And I think that was really the intent of that, and just really break it down into what the different components of the case scenario is. And once we understood that, then going through the other scenarios just, kind of followed suit. So I found it very, very educational, and it's fun. You meet like other vascular surgeons from across the country, and you get to kind of talk about the things that really bind us together as a society. So that was fun.
And on all the feedback, those are the two topics that we always get: difficult conversations and negotiation, because it's like your day to day, and it's one of those difficult skills. I really like. There's this book called "How to Influence Without Authority" and Getting to Yes, and it's like that mentality that in any difficult conversation that you need to get with the mentality that everyone could be your potential ally. And that at the end, all these negotiations, it has to be win-win. Like, you cannot, get into with the mentality that, I'm just gonna like crush this person, or both parties need to win with. At the end of those conversations because if not, you're just gonna alienate people and not move forward, right?
Absolutely, yeah.
So maybe we could talk a little bit about talent. So as a leader, you people look up to you. I think you need to learn how to manage talent, right? How do you, as a leader, you have trainees, you've got students, you've got residents and fellows, right? They're looking up to you and you're looking at them and they're trying to learn, but they have talent. So you're trying to develop them and help them become the best that they are. How do you manage talent as a leader? Any thoughts about that?
Well, I think a big part of leadership is mentorship. And I think that, that everyone says that when you're ready for that, leadership position and I keep saying that, I know that everyone's a leader, but it's really about the we and not the me. So we as vascular surgeons, especially in the academic setting, which you pointed out, Palma, because we're mentoring, students and trainees in addition to fellows, it's important to, always get people to strive and be accomplishing something, keep them a little bit on their toes. And I think that can be challenging. I think that the larger the division, it can be challenging with your different levels of faculty, to ensure that they're all progressing and aren't getting stagnant, and that they feel like they're progressing in whatever way that they want to be growing in. There has to be something in it for them. And similarly for trainees, whether it be research projects or if they really just want to present at clinical meetings, then it's really your responsibility to try to get them there or hook them up with one of the faculty members to ensure that they're getting to the meetings that are more geared towards more clinical things like that CPS or VRIC if they're basic science or translational research bent. And then at the student level, just to, if they're really just looking for someone to see if work-life balance is something that is possible in vascular surgery, getting them connected with someone where they can shadow them in clinic and in the OR and things like that. So a lot of what leadership is I guess, understanding where to plug people in with to ensure that they, can continue to progress and also can continue to be inspired by others in your division, and if you're doing good or cultivating the existing talent within your division, then you can build upon that with the trainees and students that you're mentoring as well.
Now, as a chief, how do you do that? How do you identify the people under you? How do you identify their strengths? How do you nurture that? How do you guide them? How do you, or maybe say you need to move up, or you need to urge them to move to the next level and not remain at the same level, need to maybe go for associate professor or maybe even get a different position, move to go be a chief somewhere.
Yeah, no, and that's really tough, especially, at different levels when you're hiring people, when you're like interviewing for trainees, right? Or just for somebody in your division. You can get references on how good people are clinically, or, you can look at test scores, but like looking at emotional intelligence is really tough in just a 10-15 minute interview, but that's what is going to get people out and be able to achieve what they want to. And it's tough to identify, but you just, need to invest on the people that are under or equally to you, and trust them and trying to delegate and give them things basically not try to hoard all the positions, because if not, you're not developing people, right? So you need to know how to let go and trust them and mentor them. But to answer your last question is like, how do you know if somebody is, ready to let them go? It's like, I don't think, or if they're ready for the next step. I don't think you're always like, you can be sure, but that for me, the foundation of leadership is trust, and you need to trust that they're going to do well.
Those are great answers, but I think I guess the other just like operational thing maybe that you're touching on, Palma, is that I think that regular check-ins with your faculty is important, and I think it's just so hard nowadays, right? The reality is that like if one person's in clinic, the other person's in the OR, and that means this person's an hour away at a satellite office, and you should never have more than one vascular surgeon within 10 minutes of each other, right? Because then you're not being efficient with what you're trying to do. But that makes it really, really hard to have conversations either face to face or even like on the phone. So it's really important. I'm not great at it myself. But I think regular check-ins with my trainees who are doing research with me, it's something that's really important. And I really try to adhere to that, no matter how busy of a week it's been, or I mean, my resident just had a baby, and we met like very briefly, just to touch base on his research project. But it's important, and once you understand where they are with things, then I think some of those other things that you alluded to are very natural. You know that this person's going to be well thought of for this fellowship or this position elsewhere, and it dovetails very easily into like, well, what do you think about that? Are you going to go for that? Like, I think you should go for that. I think you'd be perfect for that. But if you don't have close relationships with that person and don't really know where they are with their career or what they're wondering about, then it makes it harder to have those conversations. And then it's kind of like, well, am I supposed to reach out to them, or is my boss supposed to reach out to me? So I think having those regular check-ins.
I think that's a great point, because that not only holds that person accountable, but also gives them regular guidance too, like they were veering off a different path and you had a different idea of where the research project was going. So that's a great point. How do you change a place's or an organization's culture? That's a hard question, I would say. What are your thoughts on that, on how do you approach that, especially in big organizations or big hospital systems?
I think it depends a little bit on how you're coming into that system. If you're, someone with a title and you have the ability to change things, I think that is different than coming into the system just being hired as an assistant professor, for example. So I'll pretend that I'm someone that will have decision-making capability. I think that it happens gradually. And I'll borrow that term from Manuel, trust is very important, because you're new to a health system. People don't know how good of a doctor you are, how good of a surgeon you are. They may have heard about that. You may have a reputation, but they need to see it, and they need to believe it, and to see, your outcomes, and that, consistency of behavior, et cetera. And it can take, a good, 2 years to just get used to a health system, to, for them to trust you and to be able to make those ultimate changes. So I think that it is possible, but it does require learning where people are coming from. I don't want to say that's not possible, but I think it is possible. It's just gradual, and it requires a lot of observation and understanding why the culture is the way that it is before undertaking some of those changes.
And I mean, I would say that the important part is that you just change it. You shouldn't wait to whoever is above you to make the change. You just start doing it at your level. I mean, we all respond to somebody higher, right? Division chiefs respond to the department chair to the dean, the dean to the board. There's always somebody above, and you shouldn't be waiting for that top hierarchical to make the final decision to change culture. We can influence people. In our day-to-day, we have trainees, the vascular lab, the people you work there, just the OR. So, I feel like if you just start with the people that you're caring for, because we all have somebody under us or that we were responsible, and that's where you start the changing culture, and not wait for, and that's how you start the change. I think the people above you will realize the good work you're doing, and they'll promote you, and then you can make more change.
But I would say that when you come in and you're the new person, and let's say you change regions, maybe you're a northerner, now you're in the south, right? And I've done that. You're the outsider, and I think you have to come in, you have to listen, you have to get the tone, you have to figure out what the relationships are, who are the key influential people in the structure, and who may be your biggest opponents, and they may not be telling you that they are. And I think you have to kind of size up everything over the first 6 months or even a year, and then identify things that maybe you could make small wins, small changes. Because if you come in and try to say, but in Boston, we did this, they're going to say, well, we're in Atlanta right now, so who cares what you did in Boston? They may, so I think it's important to be forward-looking and a visionary, but also understand where you're coming from and carefully bring people along. Just as an example, offloading. I'm a big offloader for, foot partial amputations and such. And I came where I am, and they're like, oh no, we just use an offloading shoe and let them walk on it. And so that's just how they did it. But I started teaching the MPs and the PAs to offload, and they started writing all the orders to offload the patients. So now most of the patients are offloaded. So I had to sort of do a small change in culture, but I did it through the PAs in a subtle way rather than telling my partners to change how they do things. So.
No, and I mean, I agree totally. But you made that change, right? So, but the listening part I think is really important, especially at the beginning, like trying to absorb as much of the culture so you can, I mean, as you said, know who is going to be your potential ally, who do you need to work with, so it becomes your ally, right? Before you start making a lot of changes that will just make you the enemy.
I've seen it happen.
Yes.
Oh, for sure. Yep.
So what about strategy? Can we talk a little bit about how that's critically important to achieving or being a successful leader? What are your thoughts on strategy?
You want to start, Grace?
Sure. I think that, strategy is a big picture type of thing. It's a vision, and very often it's an overarching goal that one has over the course of several years. So maybe your strategy is to just be the busiest vascular surgery hospital in a specific region. And if that's the case, then you're sending all of your faculty out to surrounding clinics, and you're just trying to get as many patients as possible. And I think that from a leadership perspective, if you have a very firm sense of what that strategic vision is, that's a good thing. And then the next thing is just making sure that everyone is engaged and able to sort of jump on that, because without the proper people on that, sort of undertaking that vision, then that strategy will not necessarily come to fruition.
Yeah, I agree. We follow people that have a plan or strategy or a vision, right? So if somebody's just like, I don't know, like flying like without guidance, you are not going to follow them. So I really like this book called Start With Why of Simon Sinek. That is basically that, like we all like somebody that has a why of why they're doing will get followers and will follow that vision. But you need to have that. I mean, once you assume the position of leadership of what are your goals, what are your values, and then people will follow you. But you need, sometimes it's hard to like do that deep dive to see what are you, I mean, now that you're in that position, what are your goals, and what are you going to try to change next, so people can follow you.
I think that's really important. The why is important, right? Mm-hmm. Because you hear about these very large health systems, and they hire these really important CEOs, and they just keep buying hospitals, and you're just like a doctor, and you're one of those hospitals. That's what you work at, and it just kind of, it's like, why? I mean, I understand the strategy is just to keep buying hospitals, but I'm just like, I guess it's important to understand if you're just trying to bring more hospital systems closer to patients so that they don't have to travel as far. Is that what it is? Is it the brand name of that bigger academic hospital to that smaller area? Like, what is the purpose of that? And I think that that's important. Otherwise, I think the term, I think, is, I don't know, Palma, it just seems a little too abstract for me as a clinician. But maybe you can elaborate on that for us.
Yeah, well, I can. My perspective, well, no, I think everything is strategy, right? So, you come in and you're like, I've got to get my 5 cases done so I can get on my webinar on time. To start the day, what is my strategy? Period. How am I going to get to my webinar today on time, right? So I've got to get in there, get the consent done the right time. I got to do this. I got to talk to the techs. I got to motivate them. I got to move things along. I need to make sure I send for the next patient well in advance. So, I mean, our whole day is a strategy. I mean, for me, every day is a strategic maneuver to have a better day and to get through all my work and achieve everything that I'm doing, So it is important from the C-suite perspective. If you want to lead, you want to build a new division, you want to buy a new hospital, you want to get the C-suite to buy you a new hybrid room. I mean, that's a strategy, right? A proposal and all this other stuff. But even at every level, we do strategic things every single day. We just don't even think about it.
Is that something that the MBH, like it was like a switch for you that?
It was like the best thing I ever did. I always say that on the show. It was like, it just all makes sense now, and I'm not perfect and I could be better every single day. But I always try to look at, like, I'll say, what's Manuel thinking, or what would Manuel want to do? Well, I think he'd like to do this leadership challenge at the Charing Cross, so I'm going to invite him. And what would Grace like to do? Well, I think Grace would like to do the following, so let me ask her to do this. And I think, what does the other person want? And maybe I can help them do that. So I think we use strategy every single day to have a better day. So you get home to see your kids, or so you can actually have a nice dinner with your husband, or things like that. I know, Linda, what do you think? Do you have a strategy you use to get through your day?
Well, just like you, I mean, my strategy is to finish everything and not in a haphazard way or with bad outcomes, and then get home to my family. Pretty much is my everyday strategy. But yeah, I mean, it's really, you do it, you don't realize it, but you really do have a strategy every day. I mean, even for cases, you have strategies, right? Like plan A, if this goes wrong, then I have a plan B. And if this goes wrong, then a plan C. So I think that is important. I think, well, Palma, you may have a comment to this, but, when we talk about strategy, and Grace was talking about, why are these hospital systems buying, all these other smaller hospitals? How do you manage? So, we're talking about leadership, like in vascular surgery, from a clinical side, but, there's also the financial admin side of all the hospitals. And so I feel like sometimes the strategies do not align. And so how do you, as a leader, kind of fight that fight, or maybe it's not a fight, I don't know, come to a compromise? Because we were just talking about this the other day, like, okay, we're trying to take, good care of patients. Sometimes admin's like, we need you to operate, we need you to operate, we need you to operate more. Well, it's like faster may not be better. But that's what their strategy is, to kind of get you, get their money's worth of you. Your strategy is to take care of patients. So how do you align the two so that everybody is happy at the end?
Well, I mean, if you're dealing with the C-suite, you have to think, what are they thinking? Because that's the first thing I say.
Right.
If I were Joe Smith, the C-suite guy who wants me to work more and do more cases, but I want to take better care of patients, I have to understand how he's thinking, and then I can try to speak in his terminology or in his language about how we want good outcomes and good quality. We don't want sloppy surgery. We want shorter length of stay and no hematomas in the groin. So I stay a little bit longer in the operating room, and the patient goes home with less complications and doesn't get readmitted. And then we lose funding that way. So I think you have to look at the whole picture from beginning to end, and mostly about what they're looking at, and then try to meet them in the middle with a conversation. At least that's how I would approach that. Mm-hmm. But even the administrative support that you talk about, obviously, everybody wants, I mean, I have my own secretary, and the rest of faculty share one, but, and I feel fortunate about that, but it's really because I'm very needy. Like, I have a lot of things with the fellowship and this, so you have to look at what the person needs and decide, do I need one admin, or do I need two admins, or how many do we actually really need to be solvent, and what's the bottom line at the end of the year, really? So, I mean, I think that's a business perspective of running a practice. I don't know, Manuel, what do you have to predict how many admins you need for your division?
Yeah, like at the end of the year, depending. Yeah, we have there's this meeting with the CMO to see how, like, if we're gonna need more, we need to cut, or more APPs depending on volume, or if you want to start another program, then you make, like what you were alluding, like your strategy for the year after, right? But what, like, I was going to point that, I mean, sometimes you want to change the culture but I mean, unfortunately, your values are totally different of like the values of the healthcare institution where you work, and you realize that later on, right? And there's no way you're going to change that culture, and that's maybe when you need to start thinking, oh, maybe I need to work somewhere else, because there's no way you're going to change that.
Well, I think a lot of times you walk into a place and it's not going to be exactly, the job is always different than the job you think you took, right? It's never quite exactly what you thought you were getting into. And then I think you have to decide, can I adapt? What things are good? Well, I love the hybrid OR suite. The staff is phenomenal. Yeah, the OR is a little slow on turnover, but I can kind of get over that. I mean, you have to pick and choose what makes your day good and what things you can kind of ignore a little bit and just deal with it. At least that's how I manage.
I just touching on what we have to do as leaders in vascular surgery and speaking to the C-suite. I think that those are important conversations to have. And as you alluded to, Paula, you have to sort of speak their language. And when it comes to quality care and decreasing length of stay, those kinds of things, they feel more comfortable once they hear that we're creating pathways and trying to reduce readmissions while still decreasing length of stay and ensuring excellent outcomes. But I think it's a balance, because once we sort of achieve their trust, we want them to understand that there are some CLTI patients that will come back after the bypass, because 20% of them come back and they need wound revisions or whatever for their TMA, or sometimes patients come back after complex aortic repair, and we want them to come back. We don't want them to go to some other hospital that don't understand what their post-operative issues were after that operation. So I think it's a balance, because in vascular surgery we're just being, because of dwindling reimbursements and things like that, it does feel like a hamster wheel, like we're just being pushed to do more and more procedures and things like that. And I think that it really, we have to meet the C-suite in between. On the one hand, we do want to, decrease length of stay and do all the, increase efficiencies, as you alluded to. But we also want to make sure that they understand that we are like the linchpin within the hospital. We manage all the complications from the medical services, cardiologists, orthopedic services, the value of vascular surgery, right? So I think that if we don't somehow communicate that to them, then we're always going to be in this sort of losing battle behind cardiac surgery and other specialties that really do have bigger DRGs than us, and we're never going to have the support or the resources that we really need,
How to know our value, right?
Yeah.
No, I was gonna say a couple of years ago, Dr. Bruce Perler gave this, talk at VAM about what you were alluding, Grace, the importance of have that presence on the C-suite, so we can, they make them know what's the value as a vascular surgeon, because in a lot of places they don't value us. So the more we develop these leadership traits, the more people we'll have in the C-suite, and will be more value as a society.
We have a question from the audience. Is there a role with artificial intelligence in leadership?
ChatGPT.
Yeah, I don't know exactly, but I think you could try that. You could put a scenario in and see how, the AI would tell you how to respond. I bet there are people modeling responses, right? For example, how to manage a toxic leader. See what AI says. Maybe they'll respond to you and say, approach it this way. We'll have to check as soon as we get off the show.
I know. So
that's a fascinating question. That's a good one.
I know.
It is.
I think AI could help you in just doing collecting data. As a leader, to sort of fight your fight or, help you complete your strategy. I don't know if I'd want artificial intelligence to be my leader. Maybe that's what we need, who knows?
Well, one of my partners ran rounds on AI, and he actually put into ChatGPT, make my PowerPoint talk for me. And it actually made kind of a presentation for him. And then he presented about the fact that he used AI to develop that. So we're not sure what it's going to do yet, right?
Yeah.
Well, if we think about leadership being interactions between people and people as human beings, I don't know how non-human beings can predict what the appropriate response might be.
Yeah.
But we could take a look after this webinar.
When I proposed this webinar, I mentioned it to Ken Slaw, and he had a couple questions I thought I would bring up. So he wanted to know, how do vascular surgeons define success in leadership? What would you say is the qualities related to a good leader? What makes that you a successful leader?
My opinion, now I did not take the course, but my opinion on this has always been your legacy. And so, you know, like, because you could just tell, right? Like, for example, Julie Flashlight, like, feel like, oh, I trained under her, or like, she taught me that, or she, you know, like, she trained these people, or, you know, however that goes, that your legacy, right? Like, who you trained or who you mentored, and how you know, successful they were, or they are, is sort of your legacy, and an example of how your leadership has, you know, brought up other people from below you into important positions.
Grace, any thoughts?
Yeah, I think having influential mentorship during your training, as well as, you know, just having remarkable leaders like Julie Freischlager are obviously great examples. I think that, you know, in alluding to what we were talking about earlier about some of the challenges leading in a health system, when you see that you're actually making impact or grounds, or, you know, where prior conversations had reached an impasse with neuro-IR or interventional radiology or cardiology, I think that, you know, building those relationships and seeing the fruition of that can be a really gratifying sign of successful leadership.
Manuel?
Yeah, I agree with all that you guys have said. I mean, we all had bad leaders, right? And it's like the people that they only think about themselves and that they have huge egos. And the people that we're going to remember is the people who we know got our back, and that they mentor us and they help promote other people. They were visionary and motivational and care about everyone, right? That they were really empathetic. Because, I mean, the other people that there is just about themselves. I mean, they're not going to go anywhere. Or, I mean, they won't have a legacy, basically.
Right. Yeah. There's another question from the audience. Can we talk about the importance of diversity in leadership? I mean,
I think we talk about that all the time, right?
I know.
I mean, we're all struggling to be more diverse in the leadership roles and bring people up when they're ready, right? So they can lead and represent and underrepresented minorities, because people will emulate. They look for people that look like them, right? I mean, that's that's why we started the women's section for the SVS, right? Or that's why we just started the International Society for Women Vascular Surgeons, right? Why did we start that? We started those to help women have people that they can connect with, that they can who can model the way for them, and they can or they can turn to in a time of like a challenging circumstance when they have no one else to turn to. And as a woman or as an African American vascular surgeon, and say, I need someone that maybe comes from somewhere that I came from, that understands what I'm dealing with. But clearly, Grace.
Yeah, no, I think those are excellent points, and I'm so glad that question was asked. I think that diversity can mean so many different things too, because as you alluded to, we kind of look to other people and kind of figure out, if I put that on, would that look good on me? You know, so if you're someone that's quieter, like you see someone who may be more soft-spoken, like how do they lead? How do they kind of are they able to influence people? Whereas you see someone who's really out there, like maybe that person just isn't relatable for you. So I think that diversity in terms of gender and the other things that Paula mentioned are important, but we have to kind of think outside of that, and we need to just embrace the fact that there's just different styleship, and the more diverse we are, the more we're able to learn from each other, and I think that we'll learn new things. If we are sort of all the same in terms of the type of leader, then we're just not going to be able to learn from each other as much or influence our patients or our trainees as much.
And respect each other's differences, right? Value the fact that they don't agree with you. You know, if you don't agree with me, tell me so that maybe I can see your perspective and then we can both grow, right? I mean, maybe I'm wrong, or maybe there's something I didn't see about that circumstance that like a blind spot that I missed. So I need to, you grow more by working with people that don't agree with you all the time. At least that's how I feel. Manuel, you're actually originally from Mexico, correct? I mean, what was it like coming here? You're into this diverse environment and you've become incredibly successful. Do you have a perspective on that?
But, and that's what I love about, this country. Because, obviously, in Mexico, there was not, we're all Mexican. There's not much diversity. Maybe gender, right? But, all the jobs that I've had here, from training, is like that diversity that you get here is be so, and for me, just so much enrichment and growth. And I don't think you can be a leader or think about leadership without thinking about diversity.
Absolutely. So I think we have a few more minutes left. So I think summarizing, definitely, the sort of new age leadership, you got to be open-minded. You have to listen, observe your environment, I would say, and sort of lead by example, right? What else? Palma?
Be forward thinking and think how what you're doing right now really impacts the future, the next 3 to 5 years, and have a vision about how you want things to look.
You have to be proactive and start doing it. Like practice, and try to learn. It's a skill.
And not be afraid to fail, because I'm very used to failing. You just got to just bounce right back up and keep going.
Palma, you always say that, but I don't think you fail that. Palma always says, I fail all the time. Like, I don't know what she's talking about. She's like on every committee and
That's why I'm so good now. I just, all that practice getting back up. I'm like a weeble. You just knock me down and I get back. How is she still standing up? I don't know. Grace, do you have any closing comments?
No, this is a very important topic, and you can't start too early. So
that is
don't
true.
Wait until you're in Dr. Shaw's position or Dr. Garcia Toca's position. Start early. It's never too early to start.
Never too early. Use it every day.
That's true. Well, thank you so much for joining us, and we hope that this really helped our viewers. And sorry for January. Because besides Manuel, everybody else is in cold weather, but.
Linda, do you want to mention our next show?
Yes, so our next show, to be determined in terms of the final title, but will be on ergonomics, especially in women surgeons, and we're going to be doing a very, well, I don't know how easy. I think it's actually going to be kind of hard, but a yoga session. So we're pretty excited about that.
So put on your yoga outfit, join in, you can get your stretches in and work all those kinks out from the lead you've been wearing all day.
I'll be there.
All right. Thanks, everybody.
Great job, guys. Thanks so much.
Thank you.
Bye.
Learned a lot. Thank you.
Bye.